So we want you to take these general principles. They're just a platform for you to start to work from and apply those to whatever disease processes that you feel like you need to improve in the office setting. So again, we've got the goals of the disease of the D70 grant to improve systems and services coordination for kids with special health care needs across the state. And so in order to be able to do that on a practice level, you have to really define who are your kids with special health care needs in your practice. And so that's one of the things that we're going to ask you to do in the mock. It's going to be your third objective. So yesterday we talked about our case management objectives, and today we're going to talk about the disease management objectives. So your third mock QI aim is going to be a high-risk registry formation. And there are lots of different ways to form your high-risk registry. And I would encourage you to use lots of these methods. The first, the simplest, would be to just start with an ICD-9 list of the chronic diseases of childhood and query your database for that. And just sit down as a practice and take a look at those kids and say, okay, who are the kids on this list who really where we want to manage their disease better. We have provided an ICD-9 list in your packets. It's also on the QIDA workspace in the website that the Center for Child and Adolescent Health Advancement has used for querying databases for kids with special health care needs. So you can use that ICD-9 list. There are other ICD-9 lists that are out there. A lot of those have a lot of adult diseases. So this particular list that we've given to you is a pediatric specific list. There are also screening tools that you can use that have been very well validated. We're going to talk about a couple of those today. There are also administrative software systems that, if you have access to, are great to use. And you could even work with some of your payers. Most of the MCOs have some software system by which they're risk stratifying their patient. They're identifying the kids who are more likely to be admitted and the kids who are high cost in their populations. So if you can work with your payers to actually identify those kids who are in your practice, when I would get those lists, I was always surprised because there was always a child out there with severe mental illness that was costing $30,000 a quarter to the MCO that I really just saw every once in a while and wasn't aware of the severity of the mental illness because they weren't linking back in with the medical home. So that's always a really great tool in a way that you can work with your payers on providing better care and reducing cost. Intuitively, you know that physician referral, you've got those patients in every practice that everybody knows that you really need to have a standing appointment every Monday afternoon and every Friday afternoon with because you know that you're going to need to do something to tweak their care. So you could also work with pharmacists and, like we said, with the payers to refer those kids into your program. I felt it was important that you be familiar with at least one of the software programs that's out there. All three of the MCOs for TennCare across Tennessee use different risk stratification systems, but I've been able to work intimately with two of them, and so I know that they can provide practice level data for you in your practice if you work with them. So they can mine it down to that level. It's harder to get physician specific, but they can at least get you practice specific. But one of the premier software programs that's out there is the 3M-CRG software. And what it does is it combines consequences-based and diagnosis-based data to produce a list of people with special health care needs. But the problem is that it's claims-based. So you have to be within a specific data set for at least 6 months and have at least 2 claims with the same ICD-9 code. It's very sophisticated. It's able to look at recurrences at the level of acuity, at procedures, at the type and number of diagnoses, and link all those things together to tell you if a patient is chronically ill or high risk. It's able to identify individuals as well as population cohorts, and within a population cohort it can tell you who's high risk, medium risk, and low risk. So if you have access to this through any of your payers, it's a really great software to use, but is not really practical because of the cost and the amount of data that's required on an individual practice level. Survey-based methods, there are lots of these out here, but we're going to review 2 of those today. The questionnaire for identification of children with chronic conditions. One is a 41 question series, one is a 16 question series, and the children with special health care needs screener. These are all consequences-based surveys that you can use to identify kids with special health care needs in your practice. We're going to talk a little bit more about how that works. The disadvantage with the QUICCC is that it has to be interviewer administered. So not many practices have the personnel to be able to designate someone to sit down and ask questions or call all your patients and interview them to see if they belong in your chronic disease registry. So we're going to actually talk a little bit more about the Children with Special Health Care Needs screener soon. When you look at the difference between the kids who are identified between the survey-based methods, so the software-based methods that are based on ICD-9 and those types of things, the administrative methods, those are the people who are identified through software, and then the survey-based methods, you get a little bit of a different patient cohort. So if you look at the kids who are identified through ICD-9 lists or through claims data, and then run those kids through a survey-based screener that's consequences-based, about half of those kids would qualify as being chronically ill by survey methods. So when you do run your ICD-9 list, some of those kids may not be sick enough to be in your chronic illness registry. And then vice versa, when you identify a patient cohort by survey methods, about a quarter of those kids are not going to be identified on your ICD-9 lists. But the concordance between the two is fairly high, but it's important that you use both. So who are the kids that are identified by surveys but not likely to be identified by your administrative data, so your software programs and your ICD-9's claims-based methods? These are the kids who are more likely to have your emotional and developmental disorders. They're not coded in the encounter records. Those kids where you're not exactly sure what's going on, but there's lots of different factors that are contributing and their special needs. A lot of these kids are utilizing services that are not reimbursed underneath a traditional reimbursement structure. So they may be getting services through Children's Special Services or some other places. So that's not showing up in your administrative data. And then these are also the kids who may have multiple health conditions that in isolation do not render them chronically ill, but in conglomerate do render them chronically ill. So a lot of times they've got several different things going on in different life domains. Also, these kids are likely to be in transition. So this is survey administrative data are based on claims. So how many times have you seen a kid switch from one MCO to the other and they're just lost in the milieu of what happens at that point? So these kids are really likely to be in transition between healthcare plans or between PCPs. Again, we talked today about the MCHB and AAP definition of kids with special health care needs. So now we're going to talk a little bit about the Children with Special Health Care Needs screener. And this is something that I would really encourage you to use as an objective screener to identify kids in your practice who are chronically ill. So basically, this is not a condition-specific screener. It's a consequences-based screener. It has 5 questions, so it's easy to administer and quick to administer in the office. Parents can usually fill it out in about 30 seconds. And basically, it uses clusters of questions or sequences of questions. So you'll have 1A, 1B, 1C, 2A, 2B, 2C. The only exception to that is question 5, which has an A and a B. So a child... what the A part of the question screens for the consequence. The B part of the question screens for the presence of a medical condition. And then the C part of the question screens for how long that medical condition is likely to exist. So if you're positive to any sequence, then you would meet the criteria as being a child with special health care needs. This is not meant to be legible on the screen. It's actually in your packets and on the website as well as on the QIDA workspace, but it's basically just a copy of the Children with Special Health Care Needs screener. And we have actually gotten permission already from the Child and Adolescent Health Measurement Initiative for everybody to use this associated with this project. So you can reproduce it without concerns about copyright for the purposes of this mock project. So we talked about the grading. Basically, if mom says yes to number 1, A, B, and C, then that child meets the criteria, and you need to strongly consider them for your chronic disease registry. So there are lots of ways to put your registry together. Any one way is going to miss a significant number of your patients, so we would encourage you to sit down as a practice, start with an ICD-9 list, talk about those patients as a practice, and involve your payers, but also use an objective screening list, a consequences-based screener to consider children for entry into your registry. So once you have your registry, you've got to figure out some way to track two different things. Number one, who's been screened, because you don't want to screen everybody every time they come in, and because that's a big administrative burden. And then secondly, who is positive. I've done this both in EMR and paper-based methods. And with paper-based, it's just easy because you can pick a sticker. One color of sticker means that chart's been screened. The other color of sticker means that child is a member of your chronic disease registry, so that anyone who interacts with that chart knows that that child's a child who may need a little extra attention, may need to be worked in. You might want to talk to the nurse and the doctor about saying, no, that kid can't get in today. In terms of EHRs, almost every EHR that I've worked with in a practice has some sort of flagging ability. So you can assign a flag for the charts who have been screened and a flag for the kids who are in your chronic disease registry. And then you can build your reports around pulling those kids up every so often to see if they've done the things that you want them to do in terms of flu shots, in terms of having their plan of care, and in terms of all sorts of disease maintenance. So that's actually a fairly easy thing to do with most EMRs. And to date, I haven't come into contact with an EMR that doesn't have some sort of patient flagging ability. Maybe Star Panels, yeah. Okay, so I have come in contact with one. The Star Panel system at Vandy doesn't. But that's where you have to use. A lot of times with these systems, you think, oh, we're going to do all EMR and it's all going to work great. We're not going to have any paper. And you're like, man, the paper works better, so it has to be an amalgamation of the two. And that's what we ended up doing in my office. We would do lots of screening on paper and then scan it in, because when we tried to get it on tablets so the parents could do it, it just didn't work well. So you can choose what works best for your practice. Once you have your chronic disease registry, you want to have some sort of method of intake into your chronic disease program. And we're going to talk a little bit more about care plans, but you're obviously going to have something in the chart that designates this as a chronically ill child who's in your chronic disease registry. We, in my practice, said, okay, everybody needs a patient summary that's a comprehensive record in a few sheets of paper or a few pages on your EMR of everything that's going on with that child and what they need and where they are in their care. Some people also like to do an action plan, which is a brief synopsis of what's happened at an individual visit. You guys have copies of this tool in your packets, and they're also on the website. These are all TNAP materials, so you can feel free to change them as you like. And so, for example, on this form, we've got a place for your emergency plan. You've got a place for your plan of care. Does this particular patient have their plan of care in their chart? What type of disease states does this patient have? When was their last appointment? When are they due for their well child check? One of the things that we found in our chronically ill patient population was that the kids came in so often for management of their disease that a lot of times we forgot about their well child checks. And so that's very important that you're monitoring these kids for their well child care. And of course, most of these kids are going to need their flu shots. So you can just start with something as basic as that. Have we communicated with the family by creating a care plan, and what are the things that we want everybody in our chronic illness registry to have? And you can put that on this list and then check that off over time. So your third mock aim is to form a chronic disease registry. And so the data points that you'll be reporting on, and we're actually going to recap all the MOC data points at the end of this presentation, just in case you missed some earlier. So at baseline, we're going to be doing 20 charts, and you'll pull those charts and see if there's any objective evidence for screening for your chronic disease registry. For a lot of practices, you don't have a chronic disease registry, and that number is going to be 0, and that's fine. Then you'll institute your method for your practice of forming your chronic disease registry. You'll enter the kids with positive screens into your registry and tag the records with an identifier of having been screened or not been screened. In the monthly, you're going to pick 10 charts of the kids that you've seen that month from your general population and audit for use or audit for having been screened for entry into the registry. And I think the easiest way to do that is to use something like the Children with Special Health Care Needs Screener and just audit for the presence of that tool in the chart. So we talked a lot yesterday about case management. We know that case management is a process of screening those kids for barriers to compliance and linking them with resources that are available in your practice and your community. And I hope that you've learned a lot about some of the resources that are out there. In all reality, you're going to have 10 or 20 things that you use over and over again. They're the ones that you use the most. So it's helpful to form relationships with some of the people in the organization so that they can be your go-to, because it's really impossible to keep on the top of your brain an exhaustive list of everything that's out there, because we do have lots of resources available to us. But today we're going to switch gears a little bit and talk about disease management. So what is disease management? Again, lots of different definitions for that. Disease management is the Disease Management Society of America states that disease management supports the physician or practitioner-patient relationship and plan of care and emphasizes prevention of exacerbations and complications using evidence-based practice guidelines and patient empowerment strategies. It evaluates the clinical, humanistic, and economic outcomes on an ongoing basis with the goal of improving overall health. So that's a tall order. So there's been a lot more research on disease management than there has on even case management and care coordination. And so there are lots of great studies that look at the attributes of successful disease management programs. And so I pulled the features from two of the larger ones. One was done by Mathematica Policy and Research Policy Incorporated, and then the other was done by McKinsey Consultants. And like we talked about yesterday, one of the big things that you have to have in order to manage disease successfully is an individualized case management program that's looking at that patient not as part of a disease cohort, but as an individual. Relationship is huge, and so it's really important for that case management program to be embedded in the medical home so that the team of the physician, the nurse, the disease manager, the case manager is wrapped around that patient. When you've got that type of one-on-one relationship, there's a lot more accountability that's fostered rather than doing that over the phone or with somebody that you've never seen before. And you're able to make real-time changes in the patient's plan of care. So it's really important that is embedded in the medical home. And it's something that pediatricians are just intuitively good at. Most of us are probably doing a lot of this already. In the studies that they looked at that characterized successful programs, there was a big focus on hospital discharges and prevention of readmissions. I was really surprised to find out that about over half of the patients who are discharged from the hospital are readmitted within 9 months. And so that shows us that we are either not resolving the acute diagnosis and managing that well, or we're not giving the patients the skill sets that they need for self-management or the resources that they need to manage their disease when they go home. Most of these programs encourage use of cost-effective therapies, and they're talking about this. For example, they might give a lower copay to patients who use a generic medicine rather than a brand-name medicine. Refreshingly, the most successful programs were simple. They were generally instituted on a large scale and were very overarching, not disease-specific. They were patient-centered and had identified measurement parameters. And generally, there were incentives for the providers to buy into the program, so some sort of cost-sharing arrangement or per member per month reimbursement for participation in the program. Now again, when they were doing these studies, they were looking at adult studies. And so pediatrics is unique in every way. And so we have to look at what the differences might be for pediatrics. So in your adult cohorts, with most of these studies, you have large volumes of the same diagnosis cohort. So lots of people with hypertension, lots of people with high cholesterol. And generally in those diseases, there's a good evidence base for the therapies. And a lot of your cost and morbidity surrounds those diseases. So your people with diabetes and hypertension and high cholesterol are the ones who are having strokes and heart attacks. So a lot of the cost centers in management of those diseases. But with pediatrics, it's a little bit different. You've got very few large volume cohorts. You've got ADHD and you've got asthma and obesity, but a lot of your kids who are really the sickest are in a small volume diagnosis cohort. They're the kids with congenital heart disease and the weird genetic syndrome and seizure disorder. And for those diagnoses, there aren't that many, there's not a large evidence base for therapy of those kids. So it's a little harder to say, okay, this is how this should be treated. Everybody who is an uncontrolled hypertensive needs to be on 2 medicines at least. So it's just not as straightforward in peds. And in pediatrics, your cost and your morbidity center around those kids in those small volume diagnosis cohorts. So that kid with hypoplastic left heart syndrome in your clinic could make up more costs than all the other kids combined that month. So you just have to take a little bit different approach to disease management. So for that reason, disease management strategies in pediatrics really have to be applicable rather than just to a large volume cohort to a variety of disease states. So when you set up your processes, you kind of have to be thinking of how is this going to function for everybody. And unfortunately, we bear the burden within our offices of having needing to provide very individual case management approaches to those kids with unusual diseases, and at the same time provide population management for kids with ADHD and asthma where there are large cohorts. But yet your process has to be fluid enough to respond in a second to a large volume of kids who need a low complexity of care coordination, and then just snap to it immediately and provide really specialized, intense care coordination or disease management to that child who walks into your office frequently with some sort of chronic illness. The other thing that we have to think about is that we're primary care physicians, and formalized disease management is really a foreign concept in primary care. We think about it more in context of our tertiary care facilities. There are lots of times where you'll have a nurse practitioner, case manager, or disease manager who's with a cardiologist or a gastroenterologist, but that just doesn't happen very often, and especially pediatric primary care. And when we went out to work with our pilot sites, in our medical home pilot sites, what we saw is that there were lots of really great, very smart physicians who could rattle off the evidence base, but they were doing it all by themselves. So the plan of care was in their head. They would write that down, but nobody else in the office was going behind to say, okay, what is Dr. Smith trying to do with this patient, and how can we help manage this disease better? So the process of proceduralizing your disease management in your office is about sharing the wealth of responsibility, sharing the knowledge that's in the physician's head with the rest of the people in the office so that everybody can take part in managing the patients better. So disease manager functions. So I like to think of the disease manager who's in the thick of, somebody who's in the thick of things with the physician. So a lot of times this will be a nurse manager or a primary nurse. And their function is to support the evidence-based care or the individual care plan that the physician is coming up with. It's really important that these people have disease-specific knowledge. So they have to know how to manage asthma and what the standard is for that. They have to know what you're thinking about in terms of mental health management or obesity management. Compliance tracking and reassessment are a huge role, and they have to work as a team. They have to be able to pull Dr. Smith aside and say, hey, I'm really worried about this kid. You said that she should do this and she can't do it, so what are we going to do about this? So they really need to be able to work in real time with the team to keep communication flowing. So on a day-to-day basis, what does this look like in the office? So this disease manager, let's say if they're a primary nurse, they're passing out those screening tools that we're talking about. They're passing out your children with special health care needs screener. They're passing out your compliance barrier screener, probably with all the other screeners that you have to do in your office for developmental screening and so on. they're saying, okay, well, this child is a child that we may want to enter into our registry, and they're maintaining that for you. After you write your plan of care and they're going in to discharge the patient, they're evaluating the patient and family's comprehension of the plan and what their health literacy is. Because they may say, oh, this is a family who doesn't understand. They don't have the knowledge base to navigate what they need to get for this child or to really manage this disease. So they're going to do a lot of education for self-management, as well as linking patients who have positive barriers for compliance in with the case manager. They're going to be tracking compliance. So if that asthmatic is supposed to come back in 3 months and they don't show up, then they're calling that patient to see when they can get them back in. And if transportation is a barrier, they're calling that case manager and saying, okay, this person doesn't have a ride to come in. They are also assisting with transitions to and from the hospital, so it's really important that they're aware of what's going on. So if there's a child who's going in and out of home health or in and out of the hospital, they need to be in touch with that hospital care coordinator, the case manager at the hospital, so that they're aware of what's going on. And one thing that we always gave our disease managers the authority to do in my practice was the authority to schedule override. Even if I was completely full, they could come in and say, this person needs to come in. They need to come in right now, or they need to come in by the end of the day, because they were helping us manage that patient. So this is just a basic disease management workflow that's well documented in multiple parts of the literature. And we're just going to go through this step by step in terms of what this would look like, not only in a general sense, but this afternoon in a very specific sense with a specific disease. So you want to keep it simple. You want to form your registry, support the evidence base with process, which is hard to make that transition sometimes. You want to educate and involve your team, figure out what tools you're going to use to track your patients. You are going to continually reassess them, and it's very important. Most of the practices that we've visited were not setting regular communication times for the team, either to talk about patients or to talk about processes. So it's very important that that becomes part of your practice culture. So when you're assessing, like I said before, you're the one who's going to know the most about your patient population and what you need to do with it. So you need to be looking at what diseases you want to improve outcomes with and deciding, okay, where are we going to go first? Because you can't tackle everything at once. And you'll start reviewing the evidence base for those diseases. You need to identify the patients that you're going to be working with a specific disease. And then you start to support the evidence base with process. Identify those essential action steps that you have to do in order to support the evidence base and form an office procedure around that. It's very helpful as you're performing that procedure if you describe the responsibilities by job role. So the front office person is going to do this. The nurse who takes patients back is going to do this. The primary nurse is going to do this. The people at checkout are going to do this. The doctor is going to do this. So actually have it written out that way. It's so important for you to then communicate that plan with the staff, even if the staff aren't involved. So if they're not part of that particular care management plan, it's important that they understand what everybody else is trying to do. But the foundation of communication with everybody in the practice is going to be the physician's written care plan, and it has to be detailed enough for everybody else to know what's going on, because that's what they're going to be using to tell what's going on with the patient. So when you execute, you're going to be doing all those things that you talked about in your care plan that are evidence-based. And you know that you're going to have your case manager who's linking with community resources. They're screening for barriers to compliance. They're following up on those patients to make sure that they've been able to overcome those barriers. You've got your disease manager there as part of your team who's looking over those written care paths that you've made for your patients. They're making sure the patients have the ability to understand that and execute that. Are they using their inhaler the right way? Do they have the DME that they need to take this child who has a trach and is on a vent home? And then they're going to be referring out to case management as needed. And then the whole team needs to be going back and monitoring on a periodic basis. New needs may arise, new pathology may arise, or the patient may get better. So it's important that we're adjusting, evaluating how they're responding to medications and to therapies and to plans, and adjusting based on that throughout the course of care. So like I said, the foundation of all of this is a written plan of care, and that is essential to communicating to all of the team members. And so the AAP actually states that you should have 3 different types of plans of care. And when you're starting off, I think that can be overkill, so I would encourage you to include 1 or 2. In my practice, we started with a patient summary and an action plan, and eventually added on an emergency plan. There are lots of different examples of these in your packets. In the packet that we gave you today, there's one that I ended up using as a patient summary that is in English and Spanish. It's 11 pages long. You don't have to use all 11 pages on every patient, but it's got everything you would need, from where they go to school and who, when their last cardiology appointment was. You can put everything on there. But there are lots of different examples of patient summaries. There are a lot of great ones on the AAP toolkit, but we have several of those downloaded to the QIDA workspace for you. As well as we'll have those on the website. But you can take all of the TNAP forms and change them however you want, because those are there for you to use and change as you like. The action plan is basically a synopsis of what's supposed to be going on today. So if I'm just making a small tweak or referring to speech therapy today, you can update that patient summary from time to time, but the action plan is really, okay, what are we doing today to help with this patient? And then the emergency plan is what they take to Disney World. So if they go down there and they are a child with congenital heart disease and they become very fatigued and are having congestive heart failure, how do they get in touch with their subspecialist here? What is their usual exam? How far down is their liver usually? And where's the best place to get access? What are their labs usually like? So that's a great thing to have for patients, and can really cut down on the chaos in an emergency acute setting for the family. So your MOCQI aim number 4 is to provide a written plan of care for the team. So what you'll do is you'll take 20 patients baseline from your chronic disease registry and assess those charts for evidence of a written care plan. You'll institute your team management strategies, and then month by month you'll take 10 patients and look at those charts, 10 patients from your chronic disease registry, and look at those charts for evidence of the care plan that you've decided to use for your practice. So lots of example forms that we've got. This is the first part of the medical summary right here that is on the AAP website, the AAP action plan. These are several of the ones that I've used in the past. Your patient care plan, this is just really easy to say, okay, problem number 1, we're doing this. Problem number 2, we're doing that. You can feel free to change that how you like. So the things that you're going to be measuring, you're going to have a baseline measurement of 20 charts. You're going to screen those charts for evidence of screening for barriers to compliance, evidence of linking patients with barriers, linking patients with resources to overcome barriers to compliance, evidence of being screened for a chronic disease registry, and evidence of a written care path in the record for those who are in the chronic disease registry. Again, all of these could be 0 if you haven't instituted any of these measures. Then monthly, you're going to get 10 charts from your general population and see, okay, were these people screened for barriers to compliance? Were they screened for the chronic disease registry? Another 10 charts of people who had a positive barrier to compliance. Is there documentation that we link these kids with resources to overcome their barrier to compliance? And then the final thing that you're going to be measuring is the children with special health care needs. So take 10 kids from your chronic disease registry. Is there evidence of a written care path that you've agreed to use? So if you say, okay, this is the action plan we're going to use, and we saw these 10 kids who are on a chronic disease registry this month, how many of those kids had an action plan in their chart? Okay? So just so you're familiar with the overall aim statements for the entire project, I don't look at this as being your individual responsibility. All I expect from each practice is that they try to improve from where they are right now. But just so that you understand how we've written this program is, our goal is that the involved practices will improve chronic disease registry formation by 50% by the end of the data collection. We have that 25% of registry patients of the involved practices will have a care plan with a therapeutic recommendation and/or goal by the end of the data collection. We have the involved practices will improve screening for risk factors for noncompliance by 50% by the end of the data collection. And 25% of patients with a risk factor for noncompliance will be linked with community resources needed to promote compliance by the end of the data collection. So we're not expecting you to do everybody all the time, but we're expecting you to get the process started. So any questions about that? Okay. Yes, it's already in your books, and it's already on the QIDA workspace as well. We won't be putting that on the website because not everybody who goes to the website is taking part in the MOC program. But it's all of that is in the QIDA workspace as well as in your packets there. It's just in a little bit different format. It's not in a PowerPoint format.